office currently, and so she requested that I lead our echo for today. So thank you for having me. Just a couple reminders. Remember there's mute and unmute on the bottom of your Zoom, on the bottom left, and there's also video. You can stop and start the video as you need to. Make sure if you have your video on that you're facing the camera, and minimize any extraneous noise. If everyone would like to mute themselves during the presentations, that would be really helpful in ensuring that we have adequate audio quality, but then you're certainly welcome to unmute yourself after the presentation so that you can ask questions or join the conversation. If you have any technical issues, go ahead and let us know in the chat box as well, and we'll try to help you with that. Okay, so just to let you know, we will be recording this session for our own purposes, and in case anybody would like to view it afterwards who's part of our group. For everyone who hasn't gotten a chance to say hello, if you could just go around and quickly do that. Remember to unmute yourself before you say hello.
Hi, this is Mike Troy.
Morning, Mike.
Jeff Leichter from Sanford Health.
Morning, Jeff.
Lisa Hutchinson from Entire Family Clinics.
Hi, Lisa.
Joellen Kozlowski from Hennepin Healthcare.
Hi, Joellen.
Ellie Ratz from
Jenny
Entire Family
Colstead.
Clinics.
All right. Good morning.
This is Jenny Colstead at Open Door Health Center.
Hi, Jenny.
And Ann Thompson at Open Door.
Excellent.
Christy Hills, Lake Superior Community Health Center.
Morning, Christy.
Jamie Page from Fairview Musa Clinic in Hibbing.
Hi, Jamie.
Megan
Mirza from Alina Health.
House.
Good morning, Mirza and Megan. Okay. So first this morning, we're going to start off with our didactic presentation. And so that's going to be about a 10-minute presentation by Julie Erickson and Jamie Winter from Children's Minnesota. They're going to be talking with us about team-based care, which is principle 4 in the cross-model framework. So Julie and Jamie, are you ready?
Yep, this is Julie Erickson, and I'm going to kind of do most of the talking today for our team.
Okay, sounds great. We will get the slides up.
Great. Good morning, everybody. So I'm going to talk today about our, I'm just hesitating because I'm having like a cross. Can everybody else see the whole slide? I can see about half of it.
No, it's not filling the screen, Julie.
Okay. Okay.
We are working on that.
Okay. Do you want me to just keep talking and then? Okay, we're getting there. Okay. So again, good morning, everybody. I'm happy to talk with you about the progress that we've really made with the help of the Minnesota Health Collaborative at Children's Minnesota. I'm going to talk specifically about creating an integrated behavioral health department based on really the cross-model IBH framework principle of conducting efficient team care. My name is Julie Erickson. I'm the Director of Integrated Behavioral Health at Children's, and my colleague Jamie Winter is relatively new to Children's, but has been an immense asset as our clinic manager, both in the PEDS clinic and for IBH. So that really helps to cross into both the primary care and behavioral health worlds. And also want to acknowledge the contributions and help of Dr. Mike Troy, who's the Director of Behavioral Health Services at Children's and was the co-chair for the IBH working group for this Minnesota Health Collaborative until recently, but for the last 3 years or so. And so he and I worked really closely with the support of this group to make, implement some of these changes at Children's. We can skip through the disclosures. We don't really have any. So again, we're gonna focus on the principle of, we chose conducting efficient team care, in part because our organization was really on the front end of developing our model of integrated behavioral health as we launched into working with this group. And so I think whereas other organizations in the collaborative were maybe a little bit farther ahead or had some experience with IBH, we were really just starting and kind of taking a look at where we had some resources already deployed into some primary care clinics and felt like we really needed to work on the process and the structure of specifically the roles and workflow. So within conducting efficient team care, really in order to create a shared understanding of the work both for the primary care providers and the IBH providers in the clinics. Go to the next slide. So so these are really obviously the objectives, but the children's involvement really with both the collaborative and in ultimately a lot of it was really having the cross-model framework as a guide for our organization to go back to and to bring to our organization. That helped to create both, so that resource and creating a community expectation about integrated behavioral health that helped to result ultimately in some structural changes to clarify the IBH team member roles and responsibilities within our primary care clinics. And then the second sort of sub goal and objective we'll talk a little bit about today was within that newly formed department, really working on adherence for the IBH providers to the standardized roles and responsibilities, but also to the broader cross-model core processes and principles. So that's an ongoing process, I would say. Next slide. So just quickly as a background, we were starting to look at conducting efficient team care with we had parts of sort of fractions of FTEs for 6 providers, 2 psychologists, and 4 social workers across 2 different departments. So within behavioral health at Children's and then within the social work department at Children's. And they were embedded in 4 different clinics. So 2 clinics had 1 each of a psychologist and a social worker, our bigger primary care clinics attached to our hospitals, and then 2 social workers that were embedded in primary care clinics within our community. So really we had kind of different disciplines reporting to different managers and directors within different really departments, and then across 4 different clinics. So they had different sets of clinic managers and primary care providers and staff. And really kind of all doing somewhat different things, I would say. So that's really where our, sort of looking at our initial implementation of integrating behavioral health into primary care and getting some feedback from primary care providers, and was about kind of this lack of team care and coordinated communication. So we were having relatively low referral rates from primary care providers. They, in the clinics where there were 2 providers, the primary care providers were didn't really have a lack of clarity about the team membership or who to go to for what kinds of questions. And so we ultimately kind of enlisted the clarification from, and I would back up and say, I guess we initially tried to really work within this framework of having providers in different departments and trying to establish even within that some consistency around what the model of integrated behavioral health was going to be for children's in our primary care clinics, and then trying to have different directors or managers be implementing that. So I was working closely for a while with the manager of social work and trying to coordinate that. And so she would work with her staff and I would work with our staff, and then try to pull together for some consistency, and ran into, I guess I would say, a number of barriers and challenges for that to really create an efficient team. And so through, I would say, several iterations, and we can talk a little bit more about it, that we enlisted some clarification and assistance from our senior leadership to define really what IBH services were going to be at Children's, to have one sort of unified definition, and included in that was then, some clarifying the department structure, the composition for the integrated behavioral health team, and then their roles, responsibilities, and reporting structure. Go ahead. As part of that effort, so partly we were, really working with our senior leadership and to provide the education to them, oftentimes based on the cross-model framework and the kind of community collaborative expectations within the ICSI group, that we attempted really, and I think one of our strategies was really to try to put things in writing, which really helps to clarify for ourselves even sometimes, but to communicate and clarify kind of our current state and then even our future vision. So this was an example. Dr. Troy and I really created a whole bound summary of our work at one point with the collaborative, and then our feedback and experiences in trying to implement initially the integrated behavioral health with both psychologists and social workers in different departments. And this, I just thought was a nice example of trying to highlight the issues and again, across trying to divide out all the roles and responsibilities that we have within primary care, but this also, I think, really gave people something to respond and react to, rather than sometimes there were more just could be more kind of debate about things, and this helped to really clarify, this is what we're seeing, and could be the division of roles and responsibilities, and then we were able to kind of use this, and again, in combination with a lot of education for our leadership and within primary care and our ambulatory groups to kind of see where it was really challenging and not working very well to have providers within different departments and reporting to different people. You can go ahead. So about a year ago, I think it was October of 2018, we, within Children's, we're ultimately able to create a department, an integrated behavioral health department within behavioral health services. So I think that was a specific choice to keep it within behavioral health and to to consolidate, I think, all of the providers, whether they were licensed clinical social workers or psychologists who were providing these similar types of services for our primary care providers. So that allowed us to really create a cost center, our department, to be able to manage our own budget, consolidate again the different disciplines and across the different clinics. Actually then created this role that I have right now as the lead for that group, but then kind of gave me that clinical oversight and the management with Jamie's help to be sort of the lead and the connection for right now for our 4 primary care clinics where we have integrated behavioral health. We have an additional 8 community clinics within children's that we're hoping to expand to. So again, having, I think, one department or one lead connection is really going to be crucial in rolling out that to other clinics and using a standardized set of roles and responsibilities. So I would say it was not fast or easy to get to this point, and was probably a couple of years worth, a solid year of effort in trying to work through the model at Children's as it initially was, and ultimately that this decision, I think, was a really positive one in being able to move forward with our goals. So you can go to the next one. And really, I think we felt like now that we have a Department of Integrated Behavioral Health that we can really move forward with the clarifying the roles and responsibilities, so we can set these consistent expectations for our model of care, for our what kinds of clinical assessment and brief therapy services. So then we start to look at other, in the cross-model framework, other processes that we can implement in a more standardized way. And that we are, again, working on that across different clinics with different providers and trying to be able to be a little bit flexible within those clinics, but also adhering to kind of one standard model. You can go ahead. Our future dreams are really, as I said, one of them is to expand to our other community clinics within Children's, while at the same time, based on demonstrating our financial viability. So that's still a big piece now that we can start to standardize and look at our productivity and that sort of thing. We're then hoping to increase referrals to integrated behavioral health, implement more mutual education and collaboration, really wanting to improve the level of integration of our our integrated behavioral health providers in the primary care practice. And ultimately, hopefully next year as well, to kind of clarify our role about psychiatry. We do have a little bit of psychiatry in a couple of our clinics right now, and would like to integrate that into our model as a whole as well. Next slide. I would say in summary, I think our key points really were the continued involvement and education and support from our leadership, at all levels. And really, I think we would not have been able to make this progress without ICSI and the Minnesota Health Collaborative's support to be able to work as part of creating the, I think we had a long time, even at the beginning of this group, of just defining what integrated behavioral health was, so that, and then that's partly what led to having this cross-model framework, because it isn't just saying one thing, but it's a lot of pieces of things, and for us to be able to start with one, and then now kind of have a roadmap of where we're headed, I think has been really helpful for us, but then also for us to, again, share with our leadership. And then I think really clarifying the integrated behavioral health model. We've recently Jamie came from an organization. She joined us about 6 or 8 months ago, and came from an organization where she had a lot of experience with integrated behavioral health workflows and responsibilities, and was able to bring that to share and create more, again, documentation and to communicate both with primary care providers and again with our leadership, and also now we're creating some documents to share with our patients and families about IBH. So I think those are currently at marketing for us right now, but we would be happy to share those with the group if that would be helpful.
Great. Thank you so much, Julie. That was a great overview. Just a reminder for those of you who signed in during our presentation, if you can put your attendance in the chat box, your name and your organization. What questions does everyone have for Julie?
This is Mirza from Alina Health. I was curious, Julie, what kind of challenges, if any, you had with implementation with primary care providers and leadership?
I think the biggest challenges that we had, there's like layers of buy-in and engagement with integrated behavioral health, which is sort of like, yes, we think that's a great idea, and yes, we think our patients and our providers could really benefit from that. And then, but then kind of when the rubber hits the road, sort of the next step for us was we really need some time for our integrated behavioral health and our primary care providers to work together. I think that's our sort of next level, like I was saying, of that shared education and collaboration for them to, so we've created an IBH efficient team, but we now need to, within each of those clinics, to create an integrated primary care and integrated behavioral health efficient team, and really getting the commitment of the time on a regular basis from the primary care leadership has been kind of been an ongoing challenge, just with the other demands and expectations for primary care providers.
Thank you.
Thank you.
Other questions?
Julie, this is Jeff Leichter from Sanford Health. Thanks for your presentation. Quick question. You mentioned that you have social workers and psychologists in the role of the integrated behavioral health professional. Do they carve up the pie in any particular way, or are they both doing the same thing, or does one seem to have the lead on some other topic and others on others, or how does that work?
That is a really good question. And one I would say we continue to kind of play around with and evolve. Even though, like in that chart that I showed you, I think ideally we would like to break out the work into the social work role is more responsible for these things, and the psychologist role is more responsible for these other aspects of integrated behavioral health. And I should back up that we really only in 2 of our clinics, in our main hospital-based clinics, have both providers. So our providers that are out in our community clinics, do everything. So it's only in these couple clinics then where we're trying to have both additional resources, but also the complexity of who does what. And so ultimately I think we have some flexibility around that there are some things, for example, things like doing a diagnostic assessment and providing some brief evidence-based therapy within the clinic setting, that both the psychologist and the social worker can do and are doing. And we're trying to balance at the same time making the access for the primary care providers as easy and streamlined as possible. But in reality, it's a little bit more of who's here that day or who's available at that moment. And so wanting to also be able to have both providers be able to meet whatever the need is at the time for the IBH providers to meet the primary care providers' need. So I do think there is some differentiation, and I think it's an ongoing sort of evolution.
Julie, this is Mike, and can I just jump in for a moment? Because I think that's such an important question, and I agree with everything that you've said. And I just want to give what I wanted to say is what Julie said earlier about the work that was done to bring all the clinical resources under one department. We saw as sort of the necessary, not sufficient condition to really develop and distribute the work across different professional groups in a way that best utilized everybody's skill set and allowed for sort of overlapping, roles. But when you're, that's hard. I suspect the question is informed by a recognition that can be difficult across disciplines. What we found was that having resources come from different departments made a tough job even harder. And that getting all the resources pulled together under Julie's leadership doesn't solve all of the issues, but it gets us on a path to creating these, these roles that overlap, but also take advantage of complementary skills as well. So I just wanted to add that was a first step, in trying to, and the other thing you need is enough resources. If you don't have enough, which kind of goes to the point you were just making, then you can't really design it ideally. You kind of, you work with resources that you have to, get as much coverage as you can. But we're on the path, we're not there.
So these are really great questions. We're having a great conversation, but I want to make sure that we have enough time for everything. So if you have other questions, you're welcome to either email them in to ICSI and we can distribute them to the presenters, or you can put them in the chat box and we can make sure you get your answers. I'd like to move on to the case presentation. Thank you so much, Julie.
Sure.
The case presenter is going to be Jenny Kolstad. She is from Open Door Health Center in Mankato, and she's going to be discussing a case related to integrated behavioral health.
Hello, everyone. So I've got Ann Thompson here, who is our Director of Behavioral Health. My role is Behavioral Health Integration Coordinator, so I kind of work on trying to get some of that integrated behavioral health working in our primary care department. And then I've also got Rochelle Perry. She's our psychiatric nurse practitioner here at Open Door. She has probably the most info regarding this case. We've all kind of been involved in some way, shape, or form, but I invited her today because she has brought this up in consultation as a case she has some questions about. So we can go ahead to the next slide. So this is the situation. So, and Rochelle, feel free to jump in if maybe you got some additional stuff to say, okay? So we've got a patient with opioid use disorder, major depressive disorder, and generalized anxiety disorder. And we do have an OBOT service that we provide, office-based addiction treatment. And so this individual is being prescribed buprenorphine and clonazepam. He's frequently missing appointments and then is presenting to the clinic in crisis or calling the clinic in crisis. We've identified that his mental health symptoms are a barrier to attending his appointments. He is supposed to be attending therapy, but has no-showed. And again, I mean, I believe that it's due to mental health symptoms. He's been trying to admit to an inpatient CD treatment facility, but has been running into a lot of barriers, you know, things like Rule 25 has been scheduled weeks out, you know, and just not having any openings at the treatment centers. We've been using motivational interviewing by Rochelle. She's been trying to motivate the patient to follow through. We've had our behavioral health consultant and our nurse care coordinator work with him also on motivation to attend his appointments and to be able to follow through. And we've had our community health worker try to, you know, determine, are there, you know, financial barriers? I know transportation has been an issue for him. And when he does come in, he is very desperate for help. He wants help. He wants to get better. And, you know, we've determined, you know, mental health is one of the main barriers. You can go to the next slide. So here's some background information on him. He is on disability. He is living in income-based housing. He does have a wife, or he had a wife of 33 years, but wife had filed for divorce in 2018. And he does have history of some trauma from childhood. The reason he became addicted to painkillers following several back surgeries and hip replacement surgeries. So this was at an early age in childhood and in teenage age. He has an 8th grade level of education. He's had some domestic issues that got him in jail and on probation. He has had past CD treatment. He was on Suboxone, buprenorphine for several years when he presented to the clinic, but he had been terminated from multiple providers for quote unquote drug-seeking behavior, which was in documentation. We don't necessarily identify with drug-seeking behavior. Obviously, he's seeking the Suboxone because he needs it. He, like I said, is driving long distances to one of the providers and was having difficulty getting there because that transportation was an issue. He was purchasing the Suboxone and lorazepam off the street due to being dropped by medical providers. He reports to the providers here at Open Door that he is not drug seeking, that he just really wants help, and he voices very significant concerns regarding his mental health and reports pretty much chronic suicidal ideation daily. When he has the suicidal ideation, he kind of gets to this like, just screw it, and you know, stops doing the things he needs to get better, which I think is really common with mental health. You know, people just decide that it's not worth it and, you know, stops doing what he needs to do. He has tried multiple antidepressants that have not been helpful for him. He reports that he does want to live and he wants to get the care he needs and is scared of dying from withdrawal symptoms. So the resources that he has available is he does have a county case manager. He does have psychiatry here at Open Door. He has access to a therapist. He has the nurse care coordinator. He has behavioral health consultant. He has our community health workers. You can go to the next one. So, you know, kind of our assessment, what we've determined is that, you know, we think he needs some more intensive services, but is having the barriers with his own mental health to access those resources. And not even just his own mental health, but just the systematic barriers that exist to getting those services. And so kind of our question is, you know, we feel a little trapped, you know, there is somewhat of an ethical dilemma, like do we keep prescribing? Do we not? You know, if we stop, the patient is at risk of dying from withdrawal or suicide. It seems somewhat unethical for us to, you know, kind of quote unquote punish a patient for mental health conditions or substance use conditions. And so, you know, we kind of see that as stigmatizing. You know, he's been getting kicked out of other clinics due to, you know, his inability to follow through due to mental health and substance use, which, you know, we don't typically do that with other illnesses, you know. And so we also know that it can be dangerous to prescribe without having that follow through on the patient side. You know, if he's not attending appointments, it's not probably best practice just to keep, you know, prescribing. And we also need to address his mental health needs, which overall could help the situation. Rochelle, do you have anything you'd like to add?
Yeah, he's very complicated. He's been on Suboxone for years, along with prescribed benzodiazepine, which is not the plan and not best practice to be on Suboxone and a benzodiazepine. But we know that he's addicted to opioids, but he's also addicted to, his body's physically dependent on the benzodiazepine. So there is evidence to show that they're looking at the clonazepam, that it's not ideal practice, but you look at the situation individually. And so the goal is to get off the benzodiazepine, but we're not in any position to do that right now. And so that's the reason that he gets both. It is challenging because a lot of programs that have the office-based addiction treatment have a whole team assigned that includes, like specifically for the OBOT, we have a team that is helping now, but it does get challenging. And yeah, we just welcome any thoughts you have. I'm at a spot that I feel comfortable continuing to prescribe Suboxone for somebody, as even though they're not in treatment per se. I mean, we're working with him, but there's studies that show that Suboxone alone can help people be in recovery and not stop prescribing the Suboxone for that reason alone. So I'm getting to the point where I'm a little bit more comfortable with Suboxone alone for the time being. But yeah, appreciate any insights.
And that wraps up our presentation. So.
Okay. So thank you so much. I'm just going to walk us through the echo process here. After the presentation, we have a few minutes to ask clarifying questions about the case so you understand the details a little better. These are specifically clarifying questions. We will have time for recommendations after we complete the clarifying questions. So we are going to begin always with the spokes or learners before we go to the core hub individuals. So the spokes or learners, do you have any specific clarifying questions?
This is Karen. I'm sorry I missed his age. How old is he?
50, early 50s.
Okay, now we'll open it to the hub as well. Spokes and hubs, anyone is welcome to ask any clarifying questions.
This is Musa from Alina Health. I think I really appreciate the destigmatizing approach you have done. And it sounds like effectively you're doing a risk reduction strategy more or less. And so I admire that too. But it is a complicated case, and sometimes as complex patients, you do wonder about what could happen if you withdrew certain medications. But it's a tricky situation. I don't think there's an easy answer to that. But I did want to shout out that I really appreciate and admire that you have taken a destigmatizing approach.
Thank you.
Okay, so it sounds like the case that we are discussing is a 50-something-year-old man with opioid use disorder, major depressive disorder, generalized anxiety, is on currently Suboxone and benzodiazepines. He has been missing some of his therapy appointments due to difficulties with transportation. He has a history of chemical dependency treatment and has been attempting to admit to chemical dependency, but has encountered several barriers, including assessment and openings. The provider has been using motivational interviewing. The patient also struggles with disability and childhood trauma based on some surgeries from his youth, and those led to his current addiction. He has had legal issues in the past, and he has many resources available to him, including a county case manager, psychiatry therapist, and clinic resources such as a care manager. So we are looking for Open Doors currently comfortable prescribing the Suboxone, would obviously like the patient to increase his services and receive intensive services. And so what Open Doors is looking for in terms of recommendations would be any suggestions or input about other options to try or ways to overcome those barriers. Am I summarizing this correctly, Jenny?
Yep, I think that sounds good.
Okay, so let's open up the recommendations to the spokes specifically, and go ahead and if anyone has any recommendations on the spokes side of things.
This is Karen again. I don't know if I'm a spoke or a hub, but I'm just going to ask, do you have access to Rule 79 case management and like arms services?
Yeah, we do have access to that. I don't know if he's on medical assistance.
He's on Medicare.
Yeah, so he probably wouldn't be able to get the armed services for that.
Does Medicare cover case management?
He has county case management.
Just started. We made that referral, and so this is all just happening within the last month.
Yeah. So that has started. So he does have that. So it'd be adult mental health case management.
Right. Because typically your case managers can help them get to appointments and even, you know, arrange those for him, rides or whatever. So.
Yeah, we're hoping.
You know, he does acknowledge, because we've had these conversations, that there are some self-sabotaging behaviors that he presents with, and so we just kind of have discussions about that, and he's getting some insight slowly but surely. But yeah, I'm happy that he's going to have the case manager, and he lives in an outskirts of our area in Mankato, so the transportation becomes an issue because it's in the, you know, maybe 10 miles away. But he's looking to move closer into Mankato, but again, it needs to be subsidized housing, so that takes time. But then he can be closer to his appointments and maybe be able to access them more readily.
Hi, I'm just wondering if he's obviously used multiple SSRIs in the past. Have you guys ever looked into gene site testing for him just to see if there's a possibility of one that may work better for him?
We actually did, and based on that, so he does not, when he tries a med, he tries it for 2 to 3 days. So he doesn't give it a full trial because, you know, obviously it doesn't work as good as the clonazepam for the anxiety. Initially it was anxiety, and now he understands that the depression is a piece of it too. But based on that gene site testing, he was willing to retry a med that he had tried in the past and is now on Wellbutrin. And I think it's helping with his depression. But yes, we did do the gene site testing.
Okay, now we'll open it up to all of the spokes and hubs that are on the call. Anyone have any additional recommendations?
It's a tough case. It's kind of like, you know, we've done pretty much everything that we can possibly think of. And so, you know, I don't know if, you know, the recommendation is to just like keep at it, you know, like keep doing what we're doing, because, you know, I feel like we've tried pretty much every avenue that exists for us. So, and let's just focus on keeping him alive. You know, I don't know.
This is Ryan Engdahl with Centricare, and I was thinking the same thing just now, that I think when you find yourself in a primary care space as a mental health provider, you begin to get in contact with the cases that would never ever get to traditional sort of mental health outpatient work. And so you find yourself in places like this where we continue to do everything that we can with, you know, clients engaging at whatever levels they're capable of. And we just have to kind of roll with that and be present and make sure that the resources continue to be available for maybe when that time is sort of right or not. So I appreciate the struggle. I think we're all in the same boat.
Thank you.
This is Jeff Leichter from Sanford. I don't have a recommendation because I'm as befuddled as the rest of the group, but I do have a question. More from a therapeutic standpoint, is it seems like your team is working really, really hard to look under every rock to figure out what to do. And I just wonder if you can speak to, do you feel like he's working as hard to get better as you are to get him better?
That's a great question, and I was thinking that, like, I feel like sometimes we're working harder than he is. But once we got on a med that he bought into and was helping with the energy, I mean, he is crossing stuff off of his list of that the behavioral health consultant has sat down and kind of helped him peel back exactly what needs to be happening. So I feel like in the last month, he is putting more effort. But there was that period where I really felt, you know, when in my engagement, in just my interactions with him, that I was working harder than him, and I think the rest of the team. So I think that's a great question, and that's kind of where we just, which led to us sitting down as a group, like, what can we do above and beyond what we've already done, which led to him becoming a healthcare home patient. And so, yeah, that is a question that crosses our mind. Absolutely. Because it's a frustrating spot to be in. And yet you don't want to, I mean, it wouldn't be abandoning, but you don't want to not continue to do what you can to get them engaged. So it's a struggle. And I think part of it, like for me, just in my work with addictions, I kind of just see this as a symptom of, you know, the mental health and the addiction, right? Like these are, you know, you stop doing the things that you need to do. And so do we, I don't know. I just want to make sure we don't give up, because I see it more as a symptom of what's going on than like, you know, this kind of like willfulness, you know?
Okay, any final recommendations before we move on to a summary? Okay, so just a really brief overview of the summary recommendations. We have access to Rule 79 and ARMS. Looking into that, he does have county case management, so looking into whether those overlap or whether he does have access to other services. the recommendation about gene site testing was followed through on and actually resulted in potentially a breakthrough. And then the other thought and question was, are you working harder than the patient, and appreciating the struggle of wanting to address patient care in a mental health and substance use situation where it's kind of one of the symptoms. So we will be sending out the final recommendations after the echo today. If there, would you say, open door, that your focus questions have been adequately addressed? Are there any points that you feel you would like more clarification on or having them addressed?
I really appreciate the team's input, and I think it just supports that we just keep what we're doing the best we can, that we're not leaving anything uncovered, so I appreciate that.
Yeah, absolutely. Absolutely. Okay. So closing announcements, we will be sending out evaluation forms via email, SurveyMonkey. So please do complete those. Those are very important to us. We will also be sending out a summary and the recording of today. And our next session will be in January, which we'll be also sending out with our summary and recording. Next session is January 21st, and we will have the didactic presentation from Sanford Health and the case presentation from Entira Family Clinics. We really appreciate everybody being engaged and involved today, and we will see you guys in January. Thank you.
Thanks, Gretchen.